cloud, and we're broadcast. Here we go. Good evening, everyone. Welcome to this webinar entitled COVID-19, Vascular Manifestations of Disease, presented by Dr. John Pellerito. Tonight's webinar will focus on the vascular conditions associated with COVID-19. The AIUM is accredited by the ACCME. This webinar is designated for one AMA PRA Category 1 credit. By the conclusion of this webinar, you will be able to discuss mechanisms of vascular thrombosis caused by COVID-19, identify vascular complications associated with the coronavirus, and determine imaging modalities for specific diagnoses. As an ACCME accredited provider, it is the AIUM's policy to ensure that the content and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. John Pellerito and Darcy Belito de Luna have no disclosures. At the conclusion of the webinar, you will be able to access this webinar recording at the CME and the CMA test located on the AIUM website. Participants who complete the post-test with a grade of 80% or higher will be awarded one CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have questions for the presenter, you may type them into the question box at the bottom of your screen. You will be able to answer or submit questions throughout the webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. And a recording of this webinar will be available on the AIUM website. And now I'm pleased to turn the presentation over to Dr. John Pellerito.
Thank you, Darcy. And hello, everyone, and welcome to the AIUM webinar on the vascular manifestations of COVID-19. I would first like to acknowledge my colleagues and trainees from Northwell and Yale who assisted me in selecting the cases for this presentation. So let's start out with an introduction for the coronavirus. As many of you know, the coronavirus, also known as SARS-CoV-2, was first identified in Wuhan, China in December of 2019. The primary presentation of patients was as a lung infection or pneumonia, but we soon found that there were other multi-system manifestations and complications of the virus. And vascular thrombosis turns out to be a major feature of the infection. So what I'd like to do for the next few minutes is explore the role of imaging in the diagnosis of patients with COVID-19 infection. And what I'm going to do is not only show the ultrasound appearances of these different manifestations, but I will also be showing CT and MRI images, as they sometimes will show the abnormalities very, very well. And I will guide you through those cases in case you're not familiar with the appearance of disease on CT and MRI. So many of you do know that there are actually multiple types of coronavirus. There are 6 types of coronavirus that produce human disease. 4 of them cause mild respiratory symptoms. The Middle East Respiratory Syndrome, or MERS, and the Severe Acute Respiratory Syndrome coronavirus, known as SARS, resulted in epidemics with high mortality. And these were very well known to us, as they had reached news and were very concerning for causing a pandemic. But the virus that we're going to be referring to tonight is the SARS-CoV-2 or COVID-19 virus, which is currently causing this current pandemic and is seen to be 80% identical to the SARS-CoV virus that is associated with the severe acute respiratory syndrome. Now, let me share some statistics. These are from June the 20th of this year, and you can see that globally, there are more than 8.5 million cases of coronavirus, resulting in almost 500,000 deaths. In the United States, we see the infection in all 50 states with nearly 2.3 million cases and approximately 121,000 deaths. Coming to you from New York, we've had a very extensive experience with coronavirus, where we've seen nearly 400,000 cases and 25,000 deaths. Now, I currently practice at Northwell Health, and Northwell Health is comprised of about 21 hospitals and multiple office practices, urgent care and imaging centers throughout New York and Long Island. And we've seen over 44,000 patients with the COVID infection. These patients are seen in both the inpatient, emergency, and ambulatory settings, and we've seen that it's resulted in about 3,000 deaths. And in radiology, we've performed over 170,000 examinations in March and April in patients with COVID-19 infection. Just to give you an idea of what we've been through, our daily burn rates included about 160,000 masks, 1,000 isolation gowns a day. We've used 1.5 million sets of gloves, 6,000 face shields, and about 25,000 N95 masks each day. And you compare the number of masks used with a year ago, where we used only about 15,000 per month. So you could see that we really ran through PPE. Now, it's well known that transmission of the virus is person to person, usually during respiratory droplets. It enters the system through the nose, the mouth, the eye, and that seems to be the primary route of transmission. But we're also concerned about surface contamination, which can said to last up to 72 hours. And this is why PPE is so important. That's why we've been asking, people to be wearing masks, keeping social distancing, using gloves when necessary, and of course, additional PPE in the hospitals and office settings to try to prevent the transmission of infection. Now, the diagnosis is made through the use of nasopharyngeal swab samples, and it's the RT-PCR test. It's the reverse transcription polymerase chain reaction. You can see here in the image how it's typically obtained by placing the swab in through the nasal cavity. And there have been concerns about false negative tests, which can result from insufficient viral load, an improper collection of the sample, technical errors related to the collection, and there's a lot of controversy about the time after infection, because we know patients who test positive and then they test negative and then test positive again. So it seems to be inconsistent in terms of making a diagnosis in patients with infection. So you can have negative results and then a positive result in patients with presumed COVID-19 infection. Now let's talk about how the infection attacks the body. The virus invades cells through the ACE2 receptors. That's the angiotensin converting enzyme receptors, which are found in multiple parts of the body. These receptors, as you can see here from this diagram, they attack the cell through these ACE2 receptors. And these are particularly found on the vascular endothelial cells, in the lung, in the alveolar cells, in the cardiac myocytes, and elsewhere throughout the body, including the bowel. You could see here from the diagram that as the virus invades the cell, what happens is not only does it cause damage to the cell, but it releases cytokines and other inflammatory factors or mediators, which can elicit a severe inflammatory response, the so-called cytokine storm. And this results in a number of different pathologies, but we're going to focus primarily on the bleeding and clotting disorders, the coagulopathy associated with the release of these inflammatory markers, which can cause a number of different bleeding problems, including disseminated intravascular coagulation. So what is a cytokine storm? Well, the cytokines, as I mentioned, are these inflammatory markers. These are proteins that are involved in cell signaling and modulate the immune response or the inflammatory response. They're produced by immune cells, which include macrophages, lymphocytes, and endothelial cells. And these cytokines include interferons, interleukins, tumor necrosis factors, and other mediators. And what happens is when they're released in a great amount, they can cause this storm because as they're released into the blood quickly, they can cause a severe or life-threatening inflammatory response. So it's the marked release of all these cytokines directly into the blood that cause the cytokine storm and can produce these coagulopathies. So how did these abnormalities in blood clotting and thrombosis occur? Well, there's a lot of different theories and a lot of potential etiologies. For example, the thrombosis may be related due to the primary infection, the inflammation of the cells in the vessels, which can cause microvascular thrombosis. It may also cause clotting problems because of the severe illness that occurs, particularly in the lungs, where you have hypoxia, decreased oxygen, and thrombosis within the lungs. It causes direct hemostatic abnormalities, as we just mentioned, through the release of cytokines. And it may also be related to a number of different risk factors in patients who are sick. They're bedridden, there's problems with vascular stasis, they'll have fever and become dehydrated, can cause other problems in other organs like the liver. And so all of those can enter into the cause of these bleeding abnormalities. There are theories related to different drug therapies. Remember, a lot of the drugs that were initially used on these patients were untried and may have had complications which could involve the vascular system. And of course, particularly in New York, where our resources were overwhelmed during the initial stages of the pandemic, we did not have enough PPE, we didn't have enough healthcare personnel, and we didn't have enough equipment to deal with our very sick patients. So that also could have been a problem in terms of identifying and treating patients for thrombosis. So you can see here from this diagram, there are multiple proposed pathways for the coagulopathy or bleeding disorders in patients with COVID-19 infection. As you notice here on the left, you can see there's hemostatic derangements related to the release of cytokines and the severe inflammatory response. Here we could see it could be related to infection of the pulmonary system causing hypoxia. And of course, it may also be related to the ARDS or acute respiratory distress that was caused from that. It could be related to virus-mediated infections and abnormalities of the cells themselves. And of course, if you look here on the right side, all the other factors that have been implicated. Patients who are on mechanical ventilation, immobility, the different drugs that were tried, not only drugs that were unproven, but also drugs such as antiplatelets and anticoagulants, which may also impact on the ability to bleed normally. And of course, anyone with known comorbidities, obesity, liver dysfunction, hypercoagulable states, cancer, all of these things cause a worsening of the infection. So the hemostatic abnormalities that we see were related to a number of factors. We saw that there was a decrease in platelets, right? Thrombocytopenia is going to be related to increased bleeding. And then, of course, we had the endothelial cell injury related to invasion by the COVID-19 virus, which would result in excess thrombin production and increased clotting in a hypercoagulable state. This produced elevated D-dimer and fiber degradation products, which is really a hallmark of these clotting abnormalities. And when we saw elevated, very elevated D-dimer and these fibrin products, it was associated with a higher risk of intubation, ICU admission, and a poor outcome. So the vascular changes that we saw throughout the body were related to this thromboinflammation, right? Multifactorial, producing coagulopathy, resulting in arterial and venous thrombosis. And we see patients present with DVT, pulmonary embolism, limb ischemia. They present with stroke and myocardial infarction, just to mention a few of the problems. So we saw that this was really a multifactorial issue involving multiple organ systems. Not only the lungs, but the heart, the brain, the abdominal organs, the vessels, the musculoskeletal system, the skin, and we're now starting to realize that it also affects patients in the pediatric age group, something we didn't actually really realize until recently. So let's talk about some of the imaging modalities that we use in patients that present with presumed COVID infection. Obviously, we can use ultrasound. That has proven to be extremely valuable at the bedside for point-of-care applications. Plain field radiographs, like the chest X-ray, are extremely helpful in looking for infection in the lungs. And of course, we routinely would be using CT and CT angiography to look for evidence of pneumonia and pulmonary embolism. In selected cases, we'd also use MR, particularly in evaluation of the brain, as I'll show you. So let's start out by discussing the pulmonary manifestations. These are really the most common problems that we saw in patients who initially presented with pneumonia and pulmonary symptoms. The chest X-ray was the initial examination. We could see evidence of pneumonia. And again, this was related to the fact that the virus would enter through the respiratory tract, where there are abundant ACE2 receptors in the lungs, particularly in the alveoli. Once in those cells, there was the release of immune factors, cytokines, and then the infection would begin. The fluid would fill the lungs, where we would get all these infiltrates and patchy opacities, and result in thrombosis of these small intrapulmonary vessels. And of course, this could then lead to pulmonary embolism. So here's a look at a chest X-ray in a 28-year-old male who presented to the emergency department with shortness of breath. And the arrows are pointing to these sort of vague areas of infiltrate, these opacities in the bilateral lung fields, which represent diffuse pneumonia. And of course, this was a sign in a patient with presumed COVID-19 that they were indeed infected with the virus. And many times these patients would go on for a chest CT, and you can see here, again, with the arrows pointing to these peripheral opacities. We call these GGOs, or ground glass opacities, that we would see in a peripheral distribution in the bilateral lung fields. Very classic for COVID-19 pneumonia. And of course, chest ultrasound became very important in evaluating patients in the bedside. This scan with hypoxia and shortness of breath, and the arrows point to these increased B lines, which point to an interstitial syndrome, interstitial fluid, and possibly pulmonary edema. So these studies became very popular and are currently used to identify some of the complications that occur in the respiratory tract from the infection. So here's a scan from a 52-year-old presented to the emergency department with hypoxia. And this is an image from a chest CAT scan. And the arrows point to these dark linear areas. This is pulmonary embolism. The white areas is the contrast material within the pulmonary arteries. And you can see here that the clot is projecting from the main pulmonary artery into the right and left pulmonary arteries. This is a saddle embolus, which is very severe and causes marked blocking of these blood vessels, of course, which produce a very severe situation. And in this patient, it's not unusual to see other areas of thrombosis. Here's a portion of a Doppler ultrasound in this patient who had left leg DVT. On the grayscale image, you can see within the lumen, there's evidence of thrombus. And here we turn the color Doppler on and we can see that there's some peripheral flow, but there's clearly thrombus in the center of the lumen in the femoral vein in this patient. Moving on to some of the cardiac manifestations. We've seen patients who develop myocardial infarction, cardiac arrhythmias, arterial and venous thromboembolism, myocarditis, shock and cardiac arrest related to the virus. As we know, there's always a worse prognosis with underlying medical conditions such as hypertension, diabetes, and obesity. These injuries are related again to the myocytes themselves being invaded with the virus, which can then lead to rupture of plaque, thrombosis, and sepsis, which can lead to heart failure and death. Here's a scan from a 17-year-old male who presented with chest pain. And this is a contrast MRI. The bright areas that we see contrast material, gadolinium, and you can see here the arrows point to this peripheral rim of bright signal, and that is abnormal enhancement of the wall of the heart from inflammation. The normal myocardium is dark. That's the dark ring here that we see. That's the normal myocardium, and the bright area around the periphery is the abnormal enhancement related to inflammation. This is a scan from a 62-year-old that presented with hypoxia and elevated D-dimer. And we see a scan through the chest in a patient with right ventricular thrombus. Again, here we're looking through the heart, and we're looking at the right ventricle. The bright area is contrast material, and we see this rounded mass in the center of the lumen of the ventricle, which represents a clot in this patient. The dotted arrows point to areas of infection in the lungs. And one of the things that we found that even in patients who didn't present with respiratory symptoms, they may present with chest pain, they may present with abdominal pain, very frequently they also had underlying pneumonia. So the CAT scans that were performed for other symptoms very frequently showed underlying pneumonia. Here's an 85-year-old male that presents with pneumonia. And again, I'm showing you on the left-hand side here, the infiltration of the lung parenchyma with infection. And in this case, in addition to the pneumonia, we see a filling defect in the left atrium on this CAT scan. Here we're looking at, this is the main pulmonary artery. And here we're looking at a portion of the left atrium. And in that left atrium, we see that there's a clot, similar in appearance to what we saw in the ventricle. And again, because it's in the left side of the heart, very concerning for distal embolization. Now, this is an unusual appearance. Here's a 46-year-old that presented with severe shortness of breath. Again, the images through the chest show evidence of pneumonia. But in addition to the pneumonia, we have an unusual appearance of thrombus in the aortic arch. So here we're looking at the arch of the aorta. Here are the branch vessels coming off. And here we see the descending thoracic aorta. And we have this triangular filling defect, which represents a clot sitting within the aortic arch. It's an unusual appearance, not related to a dissection, but just from the clot settling in the aorta. And again, putting that patient at increased risk for distal embolization. Now, neurologic manifestations are not uncommon, and patients may have symptoms of stroke, epilepsy, altered mental status, and encephalopathy. This is in part due to disruption of the blood-brain barrier due to injury to the vascular endothelium. Again, the cells being invaded through those ACE2 receptors. Hypoxic injury to the brain may also be related to acute respiratory distress syndrome and inadequate ventilation. We also recognize that there's going to be coagulopathy, cytokine storm. And we found that 84% of patients were admitted to the ICU with neurological symptoms in addition to the other problems that they presented with. Here's a 59-year-old male who presented with sudden confusion. This is part of a brain CT, and the arrows point to these areas of decreased density. All these dark areas are related to edema in a patient that has infarctions related to middle cerebral artery territory thrombosis. So as you can see here, there's diffuse edema in a patient with a stroke. And further evaluation with CT angiography shows us that there is thrombus in the right internal carotid artery, producing occlusion extending into the brain. Now, it's important to utilize carotid Doppler in some of these cases. They can be extremely helpful. Here's an example of how the change in the flow pattern can be extremely helpful when there's abnormalities to the vascular system that you may not pick up routinely. All right, so we were showing this case of an 84-year-old male who presented with altered mental status following a TAVR. And the pre-TAVR carotid duplex showed a widely patent internal carotid artery and a normal waveform with a normal peak systolic velocity and normal diastolic flow, which we would expect to see because the brain demands continuous forward flow throughout systole and diastole. Following the TAVR, patient developed altered mental status. A repeat carotid duplex was done, showing a very abnormal waveform with loss of diastolic flow, indicating that there was distal obstruction. This precipitated the CT angiogram, which showed that there was thrombosis of the internal carotid artery, accounting for the symptoms. So this combination of the duplex scan and the CT angiography is very helpful in identifying the cause of the abnormality, which was carotid thrombosis. We next moved on to this 52-year-old woman who has presented with left gaze deviation. And here's an image from an MRI examination which shows abnormal signal that the arrows are pointing to in both cerebral hemispheres, indicating infarcts in the anterior cerebral and middle cerebral artery territories, indicating obstruction. This was a 29-year-old woman who presented with seizures after 1 week of cough and fever. And the arrows are pointing to an area of hemorrhage inside the left hemisphere. And again, you can appreciate here these areas of increased density representing blood in the brain. And with a follow-up angiogram or venogram in this case, we could see that this woman suffered a thrombosis of the left lateral venous sinus. The transverse sinus here is thrombosed. Notice the asymmetry. Here's the transverse sinus on the right side and the absence of the sinus on the left side. Again, spontaneous thrombosis are causing symptoms of seizures after 1 week of cough and fever related to the virus. Now, we've also started seeing a number of patients who present with abdominal symptoms. And again, likely related to some of the vascular issues that we've been discussing. Up to 40% of patients with COVID infection may have digestive symptoms, which include diarrhea, vomiting, and pain. The viral invasion occurs through the GI tract, again, through those ACE2 receptors, binds to the cell, invades the cell, causing liver and biliary disease, as well as bowel problems. And we've seen cases of bowel ischemia leading to perforation. And let me show you a case. Here's a 65-year-old who presented with abdominal pain, had a history of asthma, hypertension, and hyperlipidemia. And what this CT scan is showing you is gas within some of the veins. We see gas within the wall of the bowel, all related to hypoxia and ischemia leading to perforation. And we can tell there's perforation here because there's free air occurring within the abdomen. So not only do we see gas within the veins, we see gas in the wall of the bowel, but we also see gas outside the lumen, which indicates that there is a perforation. And we also see here some fluid within the belly marked by that asterisk. Further evaluation in this patient showed that there was thrombosis involving the superior mesenteric artery. Again, this is a contrast CT scan. We can see that there's normal enhancement of the kidneys. This is the abdominal aorta. And we can see here there's thrombus in the origin and proximal segment of the superior mesenteric artery, causing obstruction to flow to the bowel, which is producing the hypoxia, the ischemia, the gas in the veins, and in the bowel wall, leading to perforation. And you can see here the arrows are pointing to disruption of the bowel wall, the free air in the abdomen, and the fluid. So this is a patient that had bowel perforation from thrombosis of the superior mesenteric artery. Here's another example. This is a 58-year-old female presenting with abdominal pain. And again, what we're seeing here is thrombus in the superior mesenteric artery. Again, this is a sagittal view. There's the spine, obviously. This is the abdominal aorta. Here's the celiac artery. This is the superior mesenteric artery. And now you can see the absence of contrast because here's thrombosis of the SMA. And this coronal view on the right is showing that the thrombosis extends throughout the vessel into the branches of the superior mesenteric artery, again, resulting in pain, ischemia, and potentially bowel perforation. You can see all this free fluid in the abdomen. In the same patient, we also noted that there was thrombosis of the popliteal artery. On the duplex exam, we can see here, we have a longitudinal view of the popliteal artery. There's no color flow noted within the vessel. The sample volume is placed within the occluded artery, and we've angle corrected, and you can see there's no flow seen on the duplex display. And that was confirmed on the CT angiogram, which shows that the popliteal artery has an abrupt cutoff and thrombosis of that popliteal artery. So not unusual to see thrombosis involving different vessels and different organ systems. Here's a 57-year-old male who presented with abdominal pain. And because of the small vessel thromboses, we see infarcts involving the left kidney. So on the right kidney, we have relatively uniform enhancement of the kidney on this contrast CT scan. But on the left side, you can see these defects, these areas of decreased density, representing infarcts of the kidney and thrombosis of the vessels leading to those segments. This is a different patient, 52-year-old male, decreased urine output and elevated creatinine. And here you can see the largest segment of infarction. Here the entire upper pole is not perfused, as well seen on this color Doppler examination of the left kidney. We see perfusion to the lower pole, but absence of vessels in the upper pole from larger vessel thrombosis. Here's an 84-year-old male with left upper quadrant pain and urinary frequency. Here we see arrows pointing to these defects in the spleen. Here we are, left upper quadrant, right? Here are the kidneys, and we see defects in the spleen and the kidney in this patient that has multiple infarcts. If you look down below here on this coronal CT scan, you can see that there is some involvement of the bladder. And here's another view of the bladder with arrows showing marked thickening of the bladder due to the inflammation from the virus. The bladder wall should be very small, should be thin, about 2 millimeters, and you can see it's markedly thickened. And you can see other abnormalities involving the bladder. Here's an 85-year-old male that presented with hematuria, acute renal failure. And here we have a sonogram at the level of the bladder showing all this echogenic material. This is all blood clot, distending the bladder, which we see as well on the CT scan as an area of decreased increased density on the CT scan and increased echogenicity on the ultrasound in a patient that has spontaneous bleeding from the kidneys filling the bladder. This was another unusual manifestation of the COVID infection. Here's a 27-year-old female who presented with right flank pain and incidentally picked up is thrombosis of the ovarian vein. Now, this is typically seen in patients who are postpartum, develop inflammation, or who have underlying infection in a woman who presents with right flank pain. And we see that pretty well on this in contrast enhanced CT scan and also on the duplex study. And here we can see that there is blood flow in the iliac artery and vein, but the absence of flow in the ovarian vein, which is outlined here in this patient. So we've talked about a lot of different vascular manifestations, and they may be the source of many of these complications that we see from the virus. Again, resulting from endothelial damage, from invasion into the cell, producing hypercoagulability, resulting in both small and large vessel thromboembolism, which are predominant features of this disease, involving both the venous and arterial systems, causing a higher risk of death. The sicker the patient is, the greater the chances that they develop some of these problems and the greater mortality. Here's a patient that presented with bilateral upper extremity DVT. It was a 77-year-old male, bilateral upper extremity swelling, and you can see here on the left side, there's thrombosis of the left subclavian vein. We can see no flow, and we can see some collaterals there. And here we have thrombosis of the right axillary vein. So again, another example of multiple sites of thrombosis. Venous thromboembolism is seen in a higher percentage in those really critically sick COVID patients, up to 49%. Patients who are in the ICU have an even higher percentage of VTE, up to 59% at 3 weeks of hospitalization. And as you know, imaging studies can be very challenging in these patients due to their setting. Many of them are vented, they're in the intensive care unit, they may be unstable, it's difficult to get them in an optimal position. Of course, the examiner is in full PPE, has to bring a machine in the room. A lot of challenges to examining patients in that setting. We've noted increased rates of pulmonary embolism. Up to 42% of patients can have PE when they're critically ill. And chest CT is the exam of choice for diagnosing pulmonary embolism in these patients, although it can be difficult to get a CT scan when they can't be moved. And we've also seen that thrombosis in both arteries and veins can occur despite standard anticoagulation in these patients. This was a 49-year-old male who had new onset abdominal pain and elevated D-dimer. Again, elevated D-dimer, very common in these patients with these underlying coagulopathies. Here on this coronal view of a CT scan, we see absence of filling of the portal veins. This portal vein thrombosis here, outlined by these arteries, these arrows. And in addition, we see that there's thrombosis of the superior mesenteric vein, again, outlined by the arrows on the CT scan. So again, multiple areas of abnormality in patients with these clotting problems. On the ultrasound exam, Again, just as you would expect, the color Doppler study shows low-level echoes within a portal vein with a patient that has portal vein thrombosis. We can see that there is blood flow in the anterior hepatic artery, and we also see flow in the inferior vena cava. And in this patient, we see thrombosis of the superior mesenteric vein, again, the defect seen on the color Doppler study. Here was a 64-year-old male that presents with acute left leg swelling, and we see thrombosis of the popliteal vein. Again, need to look around for other areas of thrombosis. So ultrasound, as you imagine, is the preferred examination for looking for peripheral arterial and venous thrombosis. Testing should be based on clinical index of suspicion. Routine screening of these patients is not recommended. Testing should be based on symptoms and signs. And universal prophylaxis with either unfractionated heparin or low molecular weight heparin is recommended for patients who present with COVID-19 and other medical problems. Here's a patient, 51-year-old male, acute left arm pain and numbness. The CT angiogram shows abrupt cutoff here of contrast within the brachial artery. And here on the virtual reconstruction, again, you can see that cutoff in a patient with brachial artery thrombosis. In this patient, 51-year-old male with that left arm pain and occlusion, we also see that they have thrombosis of renal artery with a large infarct in the right kidney. And of course, it's not unexpected that they also have pulmonary infiltrates from pneumonia. Arterial thrombosis is seen with patients with pre-existing conditions. The reported incidence is up to 3.7%. Again, likely related to a hyperinflammatory state, but it also could be due from embolization from atrial fibrillation. And like with venous thrombosis, it can affect more than one organ at a time. Let's move on to talk about some of the pediatric manifestations. Now, there's been a delayed recognition of pediatric infections because at first we thought that the infection skipped the younger patients, the younger population. And because there were less symptoms, they resulted in less testing of kids and young adults. But when they do present, they also commonly present with pulmonary findings, but it also can infect different organs, including the heart and the brain. And recently, there's been discussion about the pediatric multi-system inflammatory syndrome that resembles Kawasaki disease. And some of these patients, unfortunately, will present with hyperinflammatory shock. Others will present with other symptoms of fever, rash, extremity pain, and GI symptoms, including vomiting and diarrhea. And it is thought to be a delayed autoimmune response to the viral infection. Here's a couple of examples in the pediatric population. This was a 2-day-old full-term infant that was born to a 32-year-old COVID-positive mother. And here we have sections through the brain that show there are bilateral ischemic changes in the thalami. You can see these areas of abnormal signal or endogenicity in both thalami. Here's a patient, 16 years old, that presented with chest pain, hypotension, and symptoms suggesting PMIS. And this was interesting. This is an unusual appearance of a dilated right coronary artery. There is failure of the normal tapering of the coronary artery here, consistent with dilatation. And here in that patient, we also see dilatation of the left coronary artery. And again, the absence of dilatation and dilatation are consistent with aneurysmal formation in this patient. And in addition to the dilatation of the coronary arteries, we also see abnormal contractility. There's a reduced ejection fraction in this patient. It was less than 50%, again, related to cardiomyopathy and decreased contractility. I'd like to finish up with just a few slides about some of the Practices that we have changed in response to the surge of patients that we saw with COVID-19. We abbreviated our ultrasound scan protocols to just answer the clinical question. So we asked our sonographers and sonologists to just obtain essential images and cine clips to reduce the scanning time and examination exposure to patients with the infection. And this included most all of our sonographic exams, including the chest, abdomen, and vascular studies. And these exams were typically performed at the bedside to avoid contamination of our examination rooms. All patients who came in during the early months were considered COVID positive, and we performed our sonographic examinations at the bedside. All of our staff wore complete PPE. That included an N95 mask, gloves, face shield, and a disposable gown. We identified a machine that was dedicated for use with our COVID suspected patients, and we made sure that we had covered our equipment with both by draping and covering the keyboard and the monitor. And the units were cleaned after every examination with the typical disinfectants. And this equipment was disinfected after every case. We tried to have a minimum of 20 minutes of downtime when patients were examined in our examination rooms to provide a room air exchange to try to clear the virus. This was also done in our CT examination rooms. We like to have at least 20 minutes of downtime to clear the air. And we reserved our MRI examinations for specific indications so that you didn't have to contaminate those rooms as well, and left them open for emergencies. So to conclude, the COVID-19 infection primarily infects the respiratory system, but we've seen it also results in multi-organ injury and failure. Vascular disease may be the source of many of these complications, and we see that as an exaggerated immune response that produces changes in coagulation as major features of the viral infection. And this results in both arterial and venous micro and macro thromboembolism that results from damage of the endothelium and hypercoagulability. Imaging plays a significant role in the detection, diagnosis, and assessment of viral complications. And a thorough knowledge of the imaging features is essential to patient care. Thank you so much for joining us today on this webinar, and in the next few minutes, I'll try to answer any questions that you may have. Thank you.
Thank you. And we do have several questions already.
Okay, Darcy. Do I have the question? Do I have
you
access?
should have them, right, that you should see like a Q&A link on the control panel.
Okay. There it is.
Yeah, right near where you were sharing your screen.
Okay, the first question that I have here is, in your experience, what is the most relevant measure of lung involvement severity with B lines, number, fractional coverage, fused B lines? Well, I have to say that we have multiple levels of experience with this. One of the things that our health system did was to try to provide ultrasound equipment to all of our ICUs and all of our medical wards, to all of our physicians who are comfortable with performing lung ultrasound, especially our critical care experts, emergency physicians. And I think they were they were doing specialized lung ultrasound protocols, and certainly the number of B lines was important, but they would do a standard protocol in these patients to try to cover as much area, looking for evidence of pneumonia, looking for areas of decreased perfusion, and looking for areas of interstitial fluid. Next question, was any ultrasound contrast used to identify obstruction in vessels? And the question is a good one. We have done some cases. I would say at our institution, there has been limited use of ultrasound contrast, but I know now that we are doing more and more cases at the bedside. I think as we're getting more comfortable using PPE, in performing these more technically challenging exams? So the answer to that is yes. We are using it at the bedside, but that has been a more recent phenomenon over the last couple of weeks. A question I think was related to one of the images. Is there a thrombus in the right renal artery too? Yes, in one of the cases that I showed that had a large area of infarction, there was thrombosis of the right renal artery. And I think that, again, it speaks to the fact that in many of our patients that present with one problem, we see additional issues that involve the vascular system, resulting in either arterial or venous thrombosis or both. Next question, does thrombosis appear more in the arterial system now as opposed to the venous system in the presence of COVID? Clinically, I'm used to seeing the venous system more affected with thrombosis, so I find it interesting you spoke about the SMA, the IC, and the popliteal artery presented with thrombosis. So the answer to your question is yes, but in fact, we're seeing much more involvement of both the venous and arterial systems. As some of the data that I presented in this presentation, we're seeing a much higher rate of peripheral DVT and a much higher rate of pulmonary embolism, in addition to the fact that we do see an increased rate of arterial thrombosis. So yes, there is more arterial thrombosis than we would typically see, but the rate is less than the number of increased cases of venous disease that we are currently identifying. So yes to both. Next question. Do you have protocols anticoagulation in COVID prophylactically prior to presentation with an actual clot and with all hospitalized patients? Okay, very good questions and ones that I really could not address during this presentation because that could require a whole nother 60 minutes. I am fortunate to work with Dr. Sparopoulos, who is a coagulation expert. He's internationally recognized, and he has put together specific anticoagulation protocols for patients who are hospitalized and also for patients after hospitalization. We do have standardized anticoagulation for our hospitalized COVID patients. I can tell you that those protocols have changed over the course of the pandemic. And so I would refer you to several of the articles that are on this list of references, particularly those by Dr. Sparopoulos that address those specific protocols. But I will also tell you that they are constantly evolving, just like with all of our treatment protocols and all the different medications that we're giving our patients now. The anticoagulation strategies are also consistently changing. Next question, wondering how many of the patients with vascular symptoms are asymptomatic? I can't give you that number. We do have a tremendous database, and that would be a really good question for me to pose to that database. How many times we were finding these areas of thrombosis, both arterial and venous, in patients presenting with completely different symptoms and signs. And I don't know exact that number, but I can tell you that we would find many of these areas in patients that were completely unsuspected. You know, patients presenting with abdominal pain where we would find PE, patients that, you know, that we were evaluating for pulmonary embolism, that had lower extremity DVT. So yes, a lot of these cases where we were identifying clots were unsuspected in patients presenting with other symptoms. And let's see. The next question, how often is intussusception in children in the setting of COVID-19? That is one question I cannot answer. I don't work in the children's hospital, and I have not come across a case of that. That's not to say it cannot occur, but I have not seen that. So that percentage is not clear to me. Next, do you think that it's important to do systemic vascular ultrasound scans for all patients with higher risk factors of VTE or arterial involvement? And the answer to that is no. I think, as I mentioned in one of the slides toward the end of the presentation, we don't want to do screening. That would certainly, as numbers surge, that would be not a good use of the services that we have. We really need to to reserve them for patients who need the studies. I can tell you that working in the hospital, a lot of our typical radiology studies were markedly reduced in volume, yet our vascular lab remained very busy. So we do not recommend screening. The studies that are coming out do not recommend screening, but only those patients that have symptoms and have signs that are concerning for underlying clotting, and certainly those patients will have very elevated D-dimers. So by looking at D-dimers and looking at symptoms, you'll know which patients are at a high risk and do require scanning.
And that's excellent. We've
great
got it
talk.
all.
Thanks, JP. Well, whoever that is, thank you.
And look at that, top of the hour. So even with our little episode there in the middle, we made perfect timing. So thank you so much, Dr. Pellerito. And on behalf of the AIUM, our thanks to all of you who participated in tonight's webinar. We hope you enjoyed the presentation and that you'll join us again for future webinars.
Thank you.
Take care.